Good afternoon. I want to welcome everybody today to UCSF Family and Community Medicine Grand Rounds. We have a wonderful panel today of family and community medicine researchers who are making a difference through their investigation and inquiry and are helping to improve health for us all. And I want to start by just sharing a few reminders about Grand Rounds. As folks have probably figured out, today's session is recorded. If you'd like to review today's session or see any Grand Rounds that you missed, please check us out on the UCSF Family and Community Medicine Grand Round websites. Everything is uploaded from past sessions. Also, if you like Grand Rounds, can't get enough of Grand Rounds, please join us for the UCSF Family Medicine Annual Rodnick Colloquium coming soon on Thursday, May 16th at Mission Bay. Hopefully you've already registered for it. I'm hoping this is not new news for anybody. Also, before we get started, I just want to say a special thanks, as always, to our tech team today, who is Benjamin Wallen and Roy Johnston, who are joining us to support this session. So much appreciated. So today's session really focuses on the role of family medicine and research. Family medicine physicians are uniquely placed to understand what research should be done to improve the ability of our healthcare system to provide equitable, patient-centered primary care. However, the culture of family medicine does not always recognize or embrace this potential, at least in part due to the perception that research is inherently disconnected from the immediate needs of the communities that we serve. In this session today, 5 family physicians who conduct research on a range of topics and use a wide range of methodologies will discuss their paths to becoming clinician researchers and how their identity as family physicians interrelates with and informs their identity as a researcher. Our panel will further reflect on the relationship of their research and of research in general to our departmental and I would say specialty mission to advance health equity. I'd like to welcome our panel today, and I'm going to just start by introducing Dr. Christine Dehlendorf, who will be our moderator today. Christine is a professor and also the vice chair for research in the Department of Family and Community Medicine at UCSF. She's also a local homegrown addition from our residency, which we greatly appreciate that. Christine also holds additional appointments in the departments of OBGYN and reproductive sciences, as well as epidemiology and biostatistics. Christine founded and directs the patient-centered reproductive health program, which aims to advance reproductive autonomy and well-being by conducting research and designing programs that center people's experiences and preferences for sexual and reproductive health and healthcare, and is guided by an attention to the intersection, oppressions, and structural injustices that impact people's health and lives. Christine provides primary care and reproductive health care at the Family Health Center at San Francisco General Hospital, Go Green Team, as well as at Planned Parenthood, and was my former linkage advisee. It is my great pleasure to welcome Christine. And if you have questions for Christine or any of our panelists, please remember to use the Q&A session all the way through for the Q&A button, all the way through to add your comments and questions so that this can be a lively, engaged discussion. Thanks for joining us.
Thanks so much, Margot. I love the additions to the bio around Green Team and linkage. That's great. So thank you so much all for being here, both in person and those of you watching later online. Myself and the panelists are thrilled to be here to talk about our work as family medicine clinician researchers. So I want to say right off the bat, this is going to be different than most research talks. We're not going to have any busy tables with research results or a discussion of statistical techniques. And in fact, spoiler alert, we actually don't even have any slides at all. You'll be looking at all of our faces for this entire time. And the reason for that is that the topic of this session is not to talk about the specifics of research and research results, but rather to talk about the generalities of doing research in family medicine as family medicine clinicians. We want to share a bit about what it looks like and what it means to have family medicine physicians who are by our nature and training generalists involved in doing research, which is so often seen as something that is specialized in ivory tower. So during this session, we are hoping that you will be encouraged to think about how family medicine clinician researchers are part of the mission of this department, which, as I think you all know, reads, never miss a chance to read it off. Our mission is to improve health through excellence and innovation in patient care, education, research, advocacy, and community empowerment. We are dedicated to building a just and equitable society recognizing that health and illness are shaped by the contexts of people's lives. So during this panel, we want you all to consider, why is research in this mission statement? How does it relate to the other parts of the mission and the overall goal of creating a just and equitable society? And what is the specific role of physician researchers in this mission? So in saying this, I want very much to underscore and acknowledge and lift up the incredible contributions of researchers in our Department of Family and Community Medicine more generally, and those who are not physicians, right? They have other trainings such as public health, epidemiology, and psychology, which is incredibly complementary to the research that is done by family medicine clinicians. So the focus of this panel on family medicine physicians is not in any way meant to take away from this critical work, which, like I said, is often collaborative with those of us from the clinical space. So at the end of the session, I'm going to share some resources about where you can go and learn more about the full spectrum of research being done in our department. By focusing in today on the work of clinician researchers, we want to stimulate thinking about the specific role of those of us who have gone through the years of clinical training and residency, and in most cases continue to provide clinical care, and why and how research can be one way in which this training and clinical experience is used to inform research to promote health justice. I am frozen on my own screen. Can you hear me? I'm getting nods from my co-panelists.
We can still hear you, Christine.
Wonderful. Okay, great. So we will plan on leaving time for questions at the end. So please think about what questions you have about research and its role in family medicine. We invite all of, especially those of you who may be cynical or skeptical about research, to be part of this conversation and ask us the hard questions. So to get us started, I'm going to ask each panelist to introduce themselves and say a bit about their area of research and how they got there, as well as to reflect on how their identity as a family physician influences their research. So to get us started, I am going to ask Dr. Hunter Holt to respond to that prompt.
Excellent. Everyone hear me? It's kind of cutting out for you, Christine, so I just want to make sure. Okay, good. Hey, everyone, I'm Hunter. I'm a family medicine physician, obviously, assistant professor at the University of Illinois in Chicago. I was a primary care research fellow at UCSF, so I have a lot of familiar faces, and I still talk to a lot of you on a regular basis. So I miss you all, and thank you so much for inviting me back. And I'm really excited to talk to you about my research and how I became a researcher. You know, when I think about when Christine approached me and asked me about this, you know, thinking about over my life and things, I always used to think about research and, you know, visions of pipettes and beakers always came to my mind, and did that in college and really didn't think that research would ever be a place for me. So that's why I really pivoted into medicine, because I thought taking care of patients was where I really wanted to be. But in medical school, you know, you really start to learn about the social determinants of health and the ways that prohibit our patients from getting the care and access that they need. And people were doing this in a research-oriented way, in a systematic way to really publish and try to change these things. And that's what got me super excited. I was like, I can do research to try to limit the amount of barriers that our patients are facing. And so that's why I decided to take a year off in medical school and went to Beijing, China as an NIH Fogarty Global Health Fellow, and did health services research in China on cervical cancer, because I knew I wanted to be a primary care provider. And for global health, there's a lot of echo, sorry. A lot of the global health topics were not related to primary care. But, you know, once I came back, I became a family medicine resident at the University of Illinois in Chicago. And in my own clinic, working at a colposcopy clinic, there was so many people that weren't showing up to their appointments that they would have no show after no show after no show. And we'd finally get them in 18 to 24 months after the initial abnormal pap smear. And thankfully, none of those were cancer, but I could easily imagine that those are situations where cancer could happen. And so you know, when you read the statistics and you see that, you know, only 14,000 people in the United States get cancer, and that the incidence rates are about 7 for when you consider the whole population. But when you think about non-Hispanic Black populations or Latinx populations, those numbers jump up to 12, 15, 16. And so almost double that of non-Hispanic white populations. That's where, and thinking about the patients I saw in my clinic that didn't show up, that's where it really inspired me to really continue to pursue that question in the United States context. I also think it's really, you know, as a person that doesn't have a cervix, To do a pelvic examination, to place a speculum in a vagina is a very sensitive examination, and I will never know what that's like. And so trying to approach that in the most trauma-informed and patient-centered way is something that I always seek to do every single time I have to do one of those exams. And so that's also a guiding principle, because it is such a tough exam for so many people, that I want to approach it in the most patient-centered and trauma-informed way possible. And so with all those things, there's so many different questions that you can ask about how do we better deliver care? How do we address these inequities that we see in cervical cancer and cancer prevention, really, delivery? And so that's why I have become a cancer researcher and a cancer prevention researcher specifically, especially as a family medicine physician. The last thing I'll say is that I think that, you know, being a family medicine physician, you're able to really inform your research by the experiences you have as a clinician. It's just such a powerful view that is not privy to everyone, that doesn't take care of it, is not in the trenches taking care of these people, doing prior auths before the meetings, et cetera. It can be very, very difficult. And how do we make those a little bit easier so that we can provide just that much better care? And I will popcorn or send it back to Christine.
Thank you. Who is having technical difficulties, so I apologize. I'm on my phone. So yeah, I would love to ask Dr. Anjana Sharma to respond and maybe share a little bit about her prior authorization she was just getting, not actually, but just recognizing the competing demands of being a clinician researcher who is also managing clinical care at the same time.
Well, that's why I was late. But I will focus on the topic at hand. I mean, I did want to say just like hello to everybody. Good afternoon to those who are here and taking your valuable time. And I also want to acknowledge there's a rally right now at UCSF for those who are watching later on. I see you, and thank you so much for your solidarity and just naming my solidarity with the students who are protesting and to the people of Gaza. So that's front of mind right now. And I think that I hope we can connect it to this talk as just as far as how advocacy and research and our careers intersect, and that's okay. That's kind of front of mind today and these times. So I wanted to name that. But I think for this talk, I would say, just to introduce myself, my research is really around patient and community engagement in healthcare and in primary care. I got to this path also as a resident. I helped start a patient advisory council at my residency at Cambridge Health Alliance in Boston. And it was so amazing to partner with patients kind of across the traditional hierarchies and really talk about quality improvement. How is our clinic perceived? How are our equity numbers for our patients? And it was so transformative. But when I went to the research, to the literature, I found nothing. I found there was no real precedent literature to discuss the evidence base for patient and community engagement in primary care. And so I very reluctantly, because I had similar experiences to Hunter as far as not thinking I was going to do research, very reluctantly looked at research fellowships and was able to talk with Kevin and really learn that the Center for Excellence in Primary Care was focusing on patient engagement at the time. And so that's really launched me on this path, very unexpected. I also did the primary care research fellowship and really worked on patient advisory councils. And so, and I will say on my very last day of research fellowship, I was told by one of the heads, "You are not a researcher, Anjana, you are an advocate." And she said it in front of everyone. And I remember feeling so like, wait, what the hell did I just spend 3 years of my, wait, what? Like, but then, I mean, I think just to name that, I think that's okay. And I think that I can now hold, I can hold on to that in a different way. And I'll just share my research mission and career mission is I am here to transform healthcare spaces into vibrant, community-led, participatory practices that promote wellness and justice. And so how that looks currently, 2 examples is we're working with our patient advisory councils, who are an amazing group of English and Spanish speaking folks who are now actively part of the residency interview process and helping to select select who are the doctors that will then lay hands on their bodies and do medical care for them. And then another example is a community engaged process for digital support and navigation to help bridge the digital divide and reduce racial and ethnic inequities that we've seen really blossom and exacerbate during the pandemic. And that's come from community, and it's with community kind of all the way through. And it's been really gratifying. So happy to talk more, and I'll popcorn it back to Christine. Thank you so much.
Right. Well, now for another perspective, we turn to Dr. Michael Potter. Over to you.
Hi, I don't know how different our perspectives are. They sound overlapping in many ways. I came to UCSF's family medicine residency program in 1990, sort of as a refugee from Harvard Medical School, where there is no family medicine department, and where I was one of 3 who went into family medicine. And here I really found a wonderful community of like-minded individuals, really focused on the health needs of our diverse, underserved immigrant communities, experiencing many upstream social determinants of health that made it difficult for them to made it difficult for them to access the care that they needed. Though I had experiences working in public health prior to medical school, I really didn't think I would be wanting to do anything besides patient care during my residency years. And I can honestly say that becoming a researcher was never a primary goal of mine either. After residency, my main goal was to become the best clinician I could be, and I actually went to work in clinical care over at the Lakeshore Family Medicine practice, faculty practice. Well, actually wasn't at Lakeshore at that time, but I was really focused on doing the full scope of family medicine, attending on the Moffitt Lung medicine wards, doing labor and delivery care, and really being in full-time practice. But gradually, questions started to come up about various things that were happening, what we could be doing better, and just noticing what are things we can do, and sort of being inspired and having opportunities to participate in our faculty development fellowship, and to take, although I didn't have the opportunity to do a formal research fellowship, I was able to take many of the courses of research courses, and I got involved in our practice-based research network. So I would say, my research has always been informed by the experiences and insights of practicing physicians who are caring for diverse communities and patient needs with limited resources. And because of that, if you were to look at my list of publications, you wouldn't really see necessarily a particular focus. It ranges from studies of many different primary care topics, such as cancer screening, smoking cessation, hypertension, diabetes care, but also on the organization of healthcare and the organization of academic institutions that seek to improve healthcare. And I've also had a chance to collaborate with everyone who's with Kevin on research, and with Hunter on research, and Anjan on her research. So my scope broadens with each of those interactions. Research projects that I'm currently engaged in that I am especially passionate about include a major study on the impact of basic universal income and earned income tax credits on cancer-related health outcomes, and another that focuses on developing and evaluating evidence-based cancer screenings in Mexico, which really brings me back to my public health roots, and what originally stimulated my interest in going to medical school. And currently, I think one of the things about being a family medicine researcher is because we have such broad impact, and because of our central role in serving as an ambassador to communities and really making sure that the patient voice is heard in research, that I've had opportunities to be involved in UCSF's Clinical and Translational Science Institute, and including its research infrastructure network, a collaborative research network, and team science programs. And that's been especially gratifying. And I think, I don't know whether I've actually answered the questions out of order that were here, that were listed, but at least that gives you a little bit of a flavor of the spectrum of activities that I've been able to be involved in. And I'm very grateful to have had that opportunity. I don't know that all academic institutions would have made way for a career such as mine. So I'll turn it back over to Christine and to Kevin.
Thanks, Mike. I want to appreciate the references people have been making to the way that clinical experience has been inspired your research trajectory and reluctantly inspired your entry into research. And also just the role of being a generalist and how that does mean that what we're looking at, our topic areas can be varied between us, but also within our career as well. So yes, Kevin, Dr. Grumback would love to hear your thoughts on the same question.
Thanks, Christine. Hello, everybody, and colleagues here on the panel. And yeah, maybe I'll start by just, Anjana, thanks for centering us a bit on the reality of what's happening in the world, because it has been those kind of experiences that, for me, that have motivated my research, because my research was really driven because like so much outraged me about what was happening in our healthcare system and broader policy stuff. And it all was grounded because all those things were so evident to me when I was in residency here, working at San Francisco General, at Family Health Center in the wards. And I said, we got to change this. And we need the knowledge and the information, and ultimately to do what you were talking about, Anjana, the advocacy to change the health system, to change society, to change the world for the better. So I was always really like motivated as somebody who saw research as a means to shape better policies and practices. And, so I was sitting there in Family Health Center and actually on the wards at General. This was the late 80s. And it was at that time, there was a crisis that was really pronounced of people who just lacked insurance completely. This was the beginning of where we started moving towards we need to have attempts to achieve more broader universal coverage. And I would sit there, like I remember on the ward, I got called down to admit somebody from the emergency department. She was a working class woman, actually had a house that she had just bought. This is, again, maybe when it was a little more affordable. And she had just been diagnosed with subacute bacterial endocarditis. I mean, the kind from having rheumatic heart disease. And she was terrified, not so much of being so sick, but that she would lose her home if she was admitted because she had no health insurance. And I was sitting there like, medical school has not prepared me. I knew actually what to do about treating somebody with endocarditis, but it didn't prepare me what to do when somebody said, because of this god-awful insurance system we have, she is pitting her economic kind of goals in life against her own health needs. And that just seemed so wrong to me. And then another time I had a patient, a family member, and I got called by the pediatric clinic and went over, and there was a toddler that I think I delivered, attended the birth with the mother. And they were in the midst of doing a lumbar puncture, and this evidently purulent spinal fluid was coming out of the needle. And it was just when H-flu immunizations had become available, and they had not come in time to get their H-flu immunizations. This is a preventable case of severe meningitis. And because of all the barriers, it was an immigrant family. Even when they had a medical home, I think it always weighed on them about costs and could they get care, and you all know the story. So all of this stuff I then started doing, researching. My initial research was a lot on the problems of uninsurance, what happens, the need to come up with a better system, how you had places like Canada and learning from them and applying that. And that was what really motivated me. And I had read some incredible research study that said, okay, this is the evidence you need, because it does show not just anecdotes, but systematically how lack of health insurance makes a difference in people's lives, how like we're wasting gazillion dollars because we let it all get sucked off by private insurance and all the administrative costs of our crazy system. Like there's better ways of doing things. I think we can come back later, talk about, does research actually change the things? I mean, but I certainly had to change me or to inform me. And so that's all my research has always been grounded in like the reality of what I was experiencing as a family doctor in my practice. And then I started looking at, well, okay, how do we promote accessibility, and looked at workforce issues. And like, I mean, there's a primary care, maybe like, well, who are the physicians working in under-resourced communities? When we look at that, what do you know? Like Black Black and Latinx physicians are disproportionately likely to be working in those communities. Okay, this is actually why affirmative action in, medical education is an evidence-based policy, because that's who is much more likely to work in the communities in the highest need. So all of that's kind of stuff. I think then experiencing how tough it was to do primary care, as it just felt like the workload was becoming so intense. That's where I started working more with Tom Bodenheimer on, like, we need to innovate and come up with different team-based models and then do the research on that and understand burnout. So everything I do, and frankly, getting back to Anjana's point about being an advocate, I think it's so much more compelling when you are a researcher. Again, not to discount people who are not clinicians, but to get up and say, I'm going to give you some research findings, some of my own research, whether you're testifying at a government thing or some other form, but to say, and you know what, this is all rooted in my day-to-day reality of still being a practicing clinician. So to me, all this has been very much a holistic approach of rooted in one's experience, and how do those experiences identify the questions that you are think important, and then how do you take the answers once you get them to try to then change those things that are upsetting you that need to be changed.
Wonderful. Thank you all so much for those stimulating comments. And I've just been inspired by all of your trajectories, both today and in general. And I want to flip the table a little bit and think we just talked a lot about how your clinical work informs your research. And I want to ask you all to reflect a little bit about how your research and your identity as a researcher interacts with your clinical role, and how you bring that into when you're interacting in the clinical space, or perhaps as an educator as well. So maybe Anjana, I'll have you get started with that one.
Oh no. Yeah, I mean, I think I guess I don't I really don't necessarily consider researcher as like a core part of my identity, but I think there's absolutely the observations working with the Patient Advisory Council, for example, that have really translated back into first a pilot, and then we then we iterate it, and then we're evaluating it, then we're writing it up. So it feels very tied, especially with the work with the Advisory Council. And then I think it also does change as I learn more about my colleagues' research. It also does shift my clinical practice. So, for example, I talk about telehealth differently, having done research in telehealth, and I am really tuned into how the team integrates with primary care with regards to telehealth, and I'm really interested in that in a different way. And then, yeah, so I mean, I think those are two just clear examples, and I'll pass it back.
Hunter, your thoughts?
It's a really, really good question. The research I think the research that I always try to do is always informed by my clinical care. And so now thinking about backwards, because I've started to do a lot more work where I'm looking at the social determinants of health and the impacts on health inequities, and how do we start to really change the system, as Dr. Grumbach has talked about. It can be really overwhelming sometimes when it feels like the answer is just like people need to realize we need to vote, or things need to change, and this, with the current political climate, this seems like it's never going to happen. So it can be a little frustrating too at the same time. But I've really started to think about how can we work within the system to really change things and improve the care that we provide. And so that's really kind of where I've started to move towards, is doing research project, or when I talk about research projects, it's about how do we improve the clinical care and the clinical things that we can provide, and also thinking about it as a systems level too. Like as a primary care provider, I know how difficult it is to try to get records from a different healthcare system when they're not on Care Everywhere. And I also have complaints about Care Everywhere and how the formatting makes it really difficult to process at the same time. And so how do we connect it better with other healthcare systems? How do we connect the community members that are in independent FQHCs or community health systems and trying to get to the tertiary healthcare systems? How do we link them better, and those sorts of issues? And so I've been really attuned to that, because that's the research area I'm moving into, but how do I act as a beacon for that? And so I've been working with FQHCs on the south side of Chicago. They often always call me, and I get texts at random times where they're like, I have a patient with dysplasia and they need to get into your colposcopy clinic. How do we get them in there? And so that's kind of the direction it's been moving towards, is I've been like this beacon for people to help get them the care they need.
Very important role. Great, Mike.
Yeah, I think there's two ways, two specific ways in which I could answer your question. One is, I think if you're a practicing physician, questions come up, and I can think of several research projects that I've been involved in that started with a clinical question, in particular, like the work that I've done in cancer screening around colon cancer screening, when we were trying to figure out how to get more people screened at the family health center, because the nurses didn't have time. They didn't have teamlets in those days, and the nurses, there weren't reminder systems, and people didn't want to ask the patient about cancer screening at every visit. So how could we do that? And a lot of brainstorming with people. And we came up with this idea, well, at least once a year, we could give people the opportunity to get a FIT kit or a colon cancer screening kit at the time of their flu shot. And so we just applied for some money, and then it grew into a big, giant series of research projects. And now people are doing this type of work all across the country. So I don't think that work would have happened if I were not a practicing family doctor in the family health center, where we had lots of barriers to overcome. And I think the other way in which being a family physician really informs my research is in the way I conduct research, because we, as researchers, researchers often apply for grants, and they say they have these ambitious ideas about what it is that they want to get everyone to do. And a lot of times it's not designed, it's an afterthought about how this work is going to happen in a clinical setting. So being the director of a practice-based research network, a lot of what I do is trying to help people to come up with realistic designs that can actually be, for research that can actually be done in clinical settings. And beyond that, research that's also going to make a difference. So in my own research, I really try very hard not to be involved in research that's not actually going to have a positive impact on all of the research participants, whether or not they got the intervention, and that's actually going to have a chance to be sustained after the research is done. And I think that's a really unique, for anyone who's in patient care and who really is an advocate for health equity and real change. These are perspectives that the family doctor really brings, and it's an appreciated, other researchers, once they realize this, the people in our teams, they really appreciate that perspective. So I think that's something that we all can bring.
Great, thanks. Lots of examples of crosstalk between our different roles. Kevin, your thoughts?
Yeah, I'm just thinking, Christine, you've assembled an unusual group of researchers, at least the other three, because see, just to hear you talking and know the work you do and how you approach it. See, the traditional paradigm in research has been, you get your study done, you publish it, and then you expect, people to read it and then change things. And it's not closing the loop and really doing it. And I think all of us are what I'd call really embedded, engaged researchers whose ultimate goal is to see how research can then translate into things being better, whether at the macro system level or in our own practice. So I think that's part of it. I feel we have a deep responsibility to take what we learned from our research and at the very least make sure that helps shape better practice environments at our own local practices. So or education, as you've asked, Christine. So it's like, if I'm going to do this research documenting why a racially, ethnically diverse health workforce is important for better access, better equity, then I better put that into practice in our own medical school and residency program, because it's not enough, if you're not, then say, okay, what are we going to do to learn from that and implement changes? Then we're not fulfilling the goal of all this. Same as we started studying, here are better models of primary care. It's saying, okay, can we get the primary care practices in the San Francisco Health Network, in the UCSF Health primary care network? How do we, implement team-based care? How do we study it? How do we make that as what might call our learning health system laboratory, not in an exploited laboratory way, but how do we apply and iterate and understand actually when you start to apply it, what are the next challenges you face? So I do feel strongly like you have to close a loop, and you have to close a loop especially in your own kind of immediate environment with what you're learning from your research.
Thanks, Kevin. I want to ask you to reflect on one of the things you said, which is that this is an unusual group of researchers, which I would agree, in an amazing group of researchers, but is it an unusual group of family medicine clinician researchers?
Well, do you want me to tackle that
Yeah,
one?
absolutely.
Yeah, I guess, good point. I think that is tends to be much more common in family medicine and primary care researchers is the sense of it being much more connected and much more grounded and much more pragmatic in thinking, like Mike is saying, like we can come up with this greatest sounding intervention to improve colon cancer screening, but like if there's no way this is going to be implemented in day-to-day practice, then that's not going to be a very good study to do. Or, and just, Hunter's thing, yeah, like now I'm doing, if my research is on cervical cancer issues, like then I got to be there when there's a clinic, caring for resourced patients, and say, well, then you need to help me link this stuff. I think that comes all the time. Anjana, like, okay, if we're going to do patient advisory councils, that's my research. Like, how do we really go deep on this stuff? So I actually do, when I see the world of primary care research, I don't know if others would agree. I'd say this is largely shared, not 100%, but probably more so in our field than in other fields, shall we say.
Great, thanks. And Anjana, I want to invite you to say something more about your comment in the chat, because I think that is really critical as well.
Yeah, I mean, I think it's really important that we use our skills to like translate research findings back to the so what. So, these studies, and also when we see really powerful, relevant studies, bringing them back, excuse me, into the clinical care space to really think if this is something we need to implement. And so, I mean, I think we have a long way to go with that. But, one example is like the SPRINT study, which found that you were supposed to drive elders' blood pressures under 120/80, but when you really looked at the methods, it was like, wait, they're sitting for like 10 minutes in a dark, silent room. They're checking it 3 times. Has anyone done primary care who did this study? Like, have you ever seen primary care blood pressure checked that way? So I think just having, and then who's actually the study? Is this a study that for people with lived experience that is relevant to patients at places like San Francisco General? So I think we need more of that. And I think, we do our journal clubs and stuff like that. But I mean, a good miss, is all the findings on pulse oximeters and finding that they're overestimating pulse ox for people with more melanin in their skin. So, that was a missed opportunity for us to really translate that into our COVID care. So I think, I think it's something that we should continue to work on.
Great, thanks. So now I'm going to ask these panelists to do something that is deeply uncomfortable for them, which is to toot their own horns. So I think we've just all made the case about how important we think it is for this work to come back, to have impact, to not just be in the peer-reviewed literature for somebody to read someday, but to have an impact on population health, on public policy, on our patients, and on communities. So if you all could give an example of a way that you've seen that play out, that would be great. So Hunter, do you mind going first again?
Would be more than happy to. I will do my best to get rid of my self-detrimental humility and say something. And I'll let, I think the moment where I was really thinking that my research has made an impact is all my geriatrician friends started quoting this New York Times article looking at cervical cancer screening in older populations. And I was like, I sent a message to them. I was like, thanks for sharing this. It was a good interview. And they're like, you were interviewed for this piece of this? And I was like, oh, you definitely didn't read it, did you? But you liked the commentary about bringing attention to cervical cancer screening in populations older than 65. And so, that's where I think coming up with questions that are pithy and, interesting to the public's eye, and I think that a lot of the questions that we ask in this, virtual room are those types of questions that are really relevant to people. They're not esoteric questions about, genes and how they impact different things. They're really about what can affect our patients today and in their own lives and what we can do to improve that. And so I think that's really how I see it impacting or getting to the public in some ways. And the message board for the New York Times was also very, very fascinating too. So that was a lot of fun for interaction between the public and like me as the scientist reading the article.
I will say, Hunter, I often think about you when I am double checking my patients' pap smear histories when they're over 65. So thank you for that. All right, Anjana, your thoughts?
Well, I mean, I think top of mind is the work with the residency interview process. And so we're just, we've scaled out the pilot year, which found really high experience rates and completely unexpected. The rate of matched residents who identify as underrepresented in medicine almost doubled from our historical average, which was not an intention of the design at all. And so to see that scaled out and then having achieved it this next year and then presenting it we were presented at NAPCRG, which is this big international primary care conference. And we had the patients co-presenting. Kevin was there. It was close to Dia de los Muertos. One of our advisors had Kim dressed in Dia de los Muertos attire. It was so then just hearing folks from Australia and the UK asking these really amazing questions. Another example was being able to support one of the shelter-in-place hotels who wanted to start an advisory council during the pandemic. And so we workshopped it. And so then being able to hold more like listening circles and having a series of listening circles to really ensure that the resident feedback was getting heard by the hotel administration. That wasn't research, but it was the research, that gets the word out, that then gets this to be an idea, that then gets it back to practice. So, yeah.
Thank you. Mike?
I mean, I guess there are so many ways. I agree that we often are doing our research and we publish our papers, and then we even do talks and we try to get people to pay attention to our work. And I think it is exciting when you see the work that you're doing sort of develop its own life outside of beyond you. So I think a lot of the work that I've done in cancer screening research, it actually has changed practices, and it's always exciting to meet someone who says that they're using it. Or if I do a web search and I see that it's, people in all 50 states and even internationally are using some of the stuff that originated in the Family Health Center from our little brainstorming session, that's really gratifying. Occasionally I'll even hear from someone who says that, the program identified someone with cancer, early cancer, whose life was saved by that. So those are certainly very gratifying experiences that can start just from, if you start with a good idea and you follow it all the way to the end, you're going to be having some good experiences, I think, and you should be able to feel grateful for your impact. I also think just by virtue of when you get into the point where you can be in a leadership role as a connector of other people or as a mentor to other researchers, that's also extremely gratifying to see. Certainly to see Anjana's wonderful career leading on patient advisory councils, and it was such a great experience working for Hunter as his mentor here. That's exciting to see and be able to see you at a conference and see that you're successful, Hunter, as we did at NAPCRG recently. And also you get a lot of prerogatives when you're in a leadership role about who you bring together for a conference or what topics get discussed. You can kind of bring your pet ideas together. And I'm just thinking about this conference we had on Monday, which to me was very inspiring, because we were talking about social determinants of health, such as housing and citizenship, and how that impacts healthcare and what we should be doing as researchers. And the idea that we could bring together people from different communities, different clinical environments, policymakers, and have like the Secretary of Housing for the state of California sitting next to the CEO of UCSF Health, and have people ask them questions about, how we can all work together to address these issues. That's very gratifying, because then we get, I think, those types of opportunities when you can bring people together can create little wavelets that can have real impact. So lots of ways.
That's amazing. Thank you, Mike. And Kevin, your thoughts on that question?
Oh yeah, maybe I may do the flip there, Chrissy, because these are so inspiring and there's so many cases. But like the challenge is when you're dealing with the broader policy environment where so much is ideologically driven. And Christine, you're like the first one to be able to speak to this. You can do the most brilliant research on, abortion access. Is that going to change a Florida legislator's decision or, that? And so this is where I found it gets really hard. I mean, I always tell my jokes, I came in with a big ego. I thought everybody would, read my articles and change the world. I had these like publications come out in major journals early in my career. Like my first one in JAMA was on, the economic benefits of a single payer program, and we could save so much money and cover everybody at the same cost. And obviously that's why we now have national health insurance in the United States, because they read it. And then my next article was on how the shift to a growing number of specialists instead of growing primary care was going to cost, the healthcare system way more than it could afford, because it's so much more expensive way to do that. At which point, like the residency programs and specialty slots doubled in the decade after I wrote that article, and we've been stagnant. And then we had this one on, the importance of racial ethnic diversity and meeting the needs of under-resourced communities. That actually got published in New England Journal, just as the regents rescinded all affirmative action in California. And then we passed Prop 209, which was passed 6 months after we published this article in New England Journal of Medicine. So it's, I have been humbled so much. And I think it just made me realize that's where the policy-oriented research collides with, there are people who are just anti-affirmative action. They're just dug in on that. There are people anti-abortion. There are people who are protecting the special interest status quo in the for-profit oriented health system. And so then I had to start thinking, okay, then you got into what is the organizing it's going to take to really change this? And it's not going to be enough just to do the research. So I think more I tried to think about, okay, how do you just do the political work? But I think there's some wins sometimes closer to home and things like that. But even on the primary care, trying to transform primary care practice, it's 2 steps forward. And, we put in teams, and then suddenly all our staff get redeployed during COVID, and the teams kind of dissipate, and then the budget crisis, hits UCSF Health or something. So it's a lot. I guess you're in it for the long haul. I think when you're doing this kind of work, no one study or one thing is going to do it. And you just sort of have to I'm going to just keep at it and keep trying to generate knowledge, keep trying to apply it, and things circle around. Like there's some of the stuff we did on racial ethnic diversity that, after things died down after Prop 209 were actually used, I think, by other interventions to bolster the case. So you kind of have to feel this stuff has some lasting value, and when the timing's right, maybe some of your work will resonate a little bit more. But it's
yeah. Thanks for the reality check, Kevin. And I do want to appreciate that. And I want to, moderator's prerogative for a second, just reflect on my own work in reproductive health, which absolutely, as you say, there's huge policy issues. But I will say this, just my trajectory around advocating for patient-centered contraceptive counseling and not promoting LARCs and IUDs and implants for people and impinging on reproductive autonomy. It had no traction when I started back in 2008. And it was very disconcerting, but it was the long haul. And in 2002, the American College of OBGYN put out a statement that was shared decision-making, non-bias, reproductive justice. And I just think that it's a reminder for me when I'm feeling disheartened in some of my current work, that it might be 14 years, 16 years, 20 years, or not our lifetime. But if we don't ask the questions that family medicine has the insight into around health equity, community engagement, what all of the various ways that we touch on our patients and our communities, then other people aren't going to ask them. And then the evidence base won't be there when the time is right. So that would be my frame. So that's that kind of is actually getting to my last question for you all, but I know we only have a few more minutes. So I encourage people to put answers in the chat or questions in the chat if you want us to answer them in about the next 5 minutes, but not seeing any yet. I'm just going to ask the panelists, you've already reflected on this in many ways, but just if you have any final thoughts or kind of summary perspectives on the role of family medicine clinicians in research. Again, you've touched on this, but just to kind of bring us to a close, it would be great to hear some final thoughts. So Hunter, you're in the hot seat.
I really love how we always approach, and I really love how UCSF and your family medicine department always calls it a family doctor. I mean, family physician is a fine too, but I don't come from a very well-off background. First generation college student, and I didn't really know the term physician wasn't part of our vernacular, my family's vernacular, until I was in college. Like we always called the doctor was the doctor. And really, when I reflect on my access to care all the way up until college, it was always a family medicine doctor, because it was me and my mom and my two brothers seeing the same doctor on the same day. And I'm sure that doctor did not like us, because that's just a crazy day, a threefer and an adult woman. But at the same time, like, as a family medicine physician and understanding and we are the first face of healthcare for so many people. And we are the people that see them, take care of them at their toughest moment and some of their best moments. But at the same time, we're also researchers, and we're able to really understand that experience and also understand how the healthcare system works in a way that we can really try to improve the healthcare system. And I think that's what's so powerful, in a way that a lot of other clinician researchers can't, right? Like, I've worked with a lot of other people from different specialties, emergency medicine, general surgery, and so their training really pins them into this tiny little hole of their specialty, which is great, and they do a lot of great research. But because of our training and because of the necessity of us to interact with every specialty, with every part of the hospital, from social workers to PTs and OTs and the pharmacists, to make sure that we're all doing these things on the same, and they're oncologists in certain cases, and the surgeons, and we are the best people to really have an understanding of how the healthcare system works and how we can get our patients the most patient-centered care in a way that they can understand and be successful in accessing that care. And so that's really my final reflection of why I continue to see patients, because it's where I find my North Star, but that's also where I find my North Star for my research as well. So I will popcorn back.
Thanks, Hunter. Anjana?
Yeah, I mean, I think I have to situate this answer within knowing the history of organized medicine and knowing the harms that organized medicine has been complicit in. From the Flexner report to complicity in slavery and eugenics, there was just a New England Journal about the New England Journal's role in the Nazi, regime. So, I mean, I need to add that big asterisk sort of on top of sort of like where we're situated. Within organized medicine, I would say I came to family and community medicine because I considered it the counterculture and sort of a beacon within. I love that word beacon, Hunter, about social change and being aligned with social movements for justice. And I mean, we're the only specialty, I think, that has community in our name. So I think the torch that I hope to carry is that we are the ethical compass, the moral compass of healthcare, and that we bring our magic is really, it's not just a cell, a DNA, a gene, it's the biopsychosocial, ecological framework. It's about the environments that shape someone's wellness and their communities that really shape someone's well-being. And so my hope is that we continue to push for better questions, better designs, and better methods that actually answer things that are actually useful for communities that we serve, that are our neighbors, that are across the street and in the counties that we serve. So that's my hope.
Hey, Chris, I see these questions. Yeah,
Can I
just out of respect to because there's been a couple of questions, Mike, unless you want to,
Well, I just have a different perspective that I was going to add to what.
So maybe have Mike answer the question, and Kevin, you can close us out with the answers. How's that?
I was just going to say, I agree with everything Hunter and Anjana just said, but I also think when we think about the importance of family medicine clinician researchers or clinicians in research, it's often as a member of it, we can lead with our ideas, or we can contribute our ideas. We can be the leaders of a project, or we can be parts of a project with other experts, like we have so many in our department. I would say much of the research that I have, maybe all the research that I've done couldn't have been done without people who have other special expertise. And I think what we bring is the perspective that's unique, and it's so important. And if it's missing, so much of the research we do will be so much less. So I think it's really important, whether you view yourself as a family physician researcher or not, we all have an important role to play in making sure that the research is good and is focused on, and we get to choose whether whether to participate. So I think it's really important. And we'll leave it there because I know Kevin has some important things he wants to say.
Please, Kevin, close us out.
There were two questions from the audience. I just didn't want to let those go. One was about, well, what about community health workers? Should we be doing research on that? I'd say, absolutely. These are exactly like, what are innovative new members of the healthcare team? How do we actually evaluate it? What are their roles? Where does it actually add value to patients, to the healthcare system, what we're trying to do? So particularly these kind of things, we need to get out ahead of it, and do the research up front to really be able to shape how to deploy, innovative team models, personnel models. So absolutely. So if any of you want to do that, do it. The other thing is, how do you communicate beyond just research publications? I think we've all learned that, like, journal articles are great. They're great on your CV. I don't want to diminish them. It's just, and often you're like, okay, I'm so exhausted by the time I finally got that darn article published. I have no energy, but that's like halfway point in your journey. It's like, then how do you actively disseminate? It's much easier when you already have people who are interested in your work kind of involved as co-creators or collaborators. So I think that's another key part, is you have to think upfront about, already, what's my dissemination strategy going to be? Who's going to be interested in that? How do I get them involved and really participating in a way and using novel communication strategies just beyond kind of the traditional publications written to try to get your information in the hands of people who can use it.
Wonderful. Well, thank you all so much for a stimulating and inspiring panel. I put the FCM research website in the chat. I encourage you all to go. Linda Pellies, our communications consultant, has done an amazing job of creating a very visually appealing and bite-sized summary of a lot of the work being done in our department. So I really encourage you just to go and spend 2 minutes with it, and you'll know much more about the research by clinician researchers and non-clinician researchers being done to advance our mission in the department. So thank you so much all for being here with us.
Thank you so much, everyone.
Thanks. Have a wonderful day. Thank you, panelists.
Thanks so much.
Thank you, audience. Bye.
Thanks, crew. Great to be with you today. Take care.